Hi, this is Dr. Bhargava, and I have a few interesting cases to share with you today. Our first case is a young patient with recent laparoscopic cholecystectomy who presented with worsening liver function tests. So on the left, we have a CT scan showing cholecystectomy clips and absence of any collection in the cholecystectomy bed. This patient underwent a HIDA scan, which shows good uptake in the liver and no excretion. So at the end of 1 hour, we see this appearance. We call this liver scan sign, and this suggests CBD obstruction. The next step in management is an MRI. So here are MRCP images showing minimal, if any, intrahepatic and extrahepatic biliary ductal dilatation with the CBD tapering towards the ampulla. And on ERCP, tiny obstructing stones were found at the ampulla, and retrospective review of the MRI showed a very tiny stone in the distal CBD. This is a non-obstructing stone, and the obstructing stone was not visualized. And so this case illustrates the importance of early identification of biliary obstruction on hepatobiliary imaging or a HIDA scan, which is or may be superior to MR imaging in this situation. Here is a good review article on the topic of laparoscopic cholecystectomy complications and the role of imaging. Our next case is a patient who presented with a vulval mass arising from the clitoris, which was diagnosed as a vulval melanoma. She underwent a whole body FDG PET CT. Here's the rotating image. These images show that the primary tumor in the vulva is hypermetabolic, as seen here, and there are hypermetabolic bilateral inguinal lymph nodes suggestive of metastatic disease. For local staging, this patient also underwent an MRI of the pelvis, which shows this T2 intermediate to high signal mass in the vulva on the axial image, sagittal image, and the coronal projection. The interesting thing about melanoma is that because of the intracellular melanin content, these are T1 hyperintense, and that's exactly what we see here, T1 hyperintensity from the melanin seen on the T1 fat saturated image. The next image is the contrast enhanced T1 weighted image, a small field of view showing contrast enhancement, and later we have DWI and ADC images showing restricted diffusion. This is a good review article on MR imaging features of vaginal malignancies. Our next patient has history of cervical cancer post-treatment, and she underwent a whole body FDG PET CT. Here's the rotating image. Her cervical cancer had responded well to chemoradiation, and on this whole body FDG PET CT image, we don't see any local recurrence. We don't see any definite evidence of metastatic disease in the chest, abdomen, and pelvis, but we do see this linear, ill-defined focus of mild to moderately intense FDG uptake, which on these fusion images and the CT corresponds to the central venous catheter. And this is a right upper extremity PICC line at the distal end of which we see FDG uptake. So we have catheter related focal FDG uptake. And so what do you make of it? So this finding suggests that there is a thrombus or infection at the site of focal FDG uptake surrounding the distal central venous catheter. Here is an article related to that, catheter related focal FDG activity on PET CT, which suggests either thrombosis or infection. Thank you for watching.